everybody. I would like to welcome you to our Vascular Ultrasound Master Class. After a short summer break, we would like to restart a monthly reading and interpretation class. Today, I have a guest, Stephen Toe, who is my lead tech in our vascular lab. We brought you two incredible cases. I just hope that you will learn something from these two cases. Before we start our cases, I just would like to invite you, if you'd like to ask questions from us, please text DeBakey to the number 37607. You see it on the screen, or on the website you can log into pollev.com and enter DeBakey and ask your questions. Between the two cases and also the end of the presentation, we'll give you a chance to review these questions. Before we start, I also would like to invite you and kind of save the date for our annual meeting, which is the Vascular Ultrasound Master Class on October 24th. This is going to be a virtual conference. We're not going to have a hands-on session, but we'll have case reviews. And to prepare for this virtual conference, I would like to invite you to look at our on-demand video series for last year's conference, because last year we reviewed all our protocols. So after reviewing the protocols, I think it would be tremendous value to really see our cases. So please search for our on-demand lecture for last year. So last year videos will be available with CME credits, and these are 2 4-hour classes, and I think after that you will enjoy our conference so much better. Also, you can mark your calendar for the next month, upcoming month's talks. We'll have some magician, we'll also invite some cats, and finally we'll close with the Top Gun. Dr. Pete is going to talk about Air Force or AVF studies on ultrasound. And again, thank you so much for joining us. I would like to start with the first case. This is a case presentation from Travis, who is our 4th-year vascular surgery resident. He was a physician in charge, and again, Stephen was my sonographer who did this study. I would like to present you a 64-year-old male who was doing some fishing in Galveston, and 2 days after the stingray marked his arm, he came to our hospital. First, after the accident, he went to an outside hospital, and the EMS brought him with the bleeding. And when he came to our hospital, he was already given antibiotics, and he already had the wound washed and cleared. And he came to our hospital, but without any major symptoms. Patient denied any pain, numbness, tingling, or weakness. Past medical history was significant just for a prior embolic stroke. He had AFib. You will see that maybe we don't see that on the next upper extremity arterial study. So after a successful ablation. On a physical exam, but I think it's noticeable, is high blood pressure. Otherwise unremarkable. And again, what I would like to point out that we have a positive modified Allen test, and there was no motor or sensory deficit on the right hand. Labs were normal. COVID test was negative also. What I would like to show you, this is the x-ray, and sometimes you don't believe that you see too much thing on the x-ray, but this is the path, the stringy bar, and you will see there's some residual tissue here, which is again hopefully not from his arm. I would like to pass the computer access to Steve, and Steve going to show you his beautiful pictures of this upper extremity arterial study. Please tell us how did you meet with this patient?
Sure. So coming into this exam, I knew the typical history that he did have a pseudoaneurysm. That's pretty much what we were initially looking for. A couple things that I wanted to also think about was there actually a formation of a fistula as well. These are kind of things that we would kind of look for. So kind of just diving in, we're looking at starting from the right subclavian artery. A Doppler signal. We can see that it is triphasic and has great signal. Moving down distally, so we're doing some more Doppler imaging. Still triphasic. We can see that the third phase does go beneath, and we do have like almost nearly a zero end diastole. Moving down to the axillary artery, so everything's still very patent, smooth intimal lining. We don't see too much calcium. Everything's moving antegrade. Waveforms are still similar. Move down to the brachial artery at the proximal segment. Some color flow. And you can see here that we actually have a branching. So here I'm actually insinuating a branch that moves deeper. So maybe, what do you think, Dr. Garami, like breast, something that moves towards the breast?
Possible.
Possible, right? So the brachial artery is actually superficial on top. We can see here that this is very high resistant and triphasic, but as we kind of continue down the arm...
Can you go back?
Sure.
I think it's an important point what you just said. We know that this is a high resistance waveform compared to the previous one.
Right.
Go back to one. So you know that branch doesn't go down to the arm because you already saw a lower resistance diastolic flow in the previous waveform.
Yes.
So I think that's very important, thinking that that is a branch doesn't go towards the arm, but definitely goes somewhere else. Very good.
Right.
Thank you.
All right, moving on to there. So we can immediately see a completely different waveform here, right? Low resistant. It still has like a triphasic Doppler signal, a very healthy signal, but obviously there's something completely different or something going on.
Oh, can you go back? I just
Sure.
would like to critique the picture a little bit more. Would you think the rhombus and your angle box should be on other opposite direction?
It could. There, technically, yes. It's kind of slanting a little bit more downward to the left. So, if we're talking about technicality, you should, you should be facing the rhombus the opposite direction.
I think that's very important to really discuss. That again, these are gorgeous pictures.
Mm-hmm.
I think I would score 10 out of 10 because I think you see images from one end to the other end. Your probe is a perfect position. I just think that those are the few, again, how can you make it even better? Or again, these are our teaching points that how can, and again, to pointing out that you're expecting a low resistance waveform, not really. So I think at this point you really wanted to see a high resistance, and you're surprised that you're seeing this much end diastolic flow on this waveform.
Right. Immediately, your mind should kind of go towards like, is it actually something more than just a pseudoaneurysm, right? Mm-hmm. I mean, is there a fistula, possibility of a fistula? I mean, it is a spear kind of stabbing through an artery, right? So, okay, just kind of moving distally, just continue to move downward. Again, we see a similar waveform.
Okay, the beautiful things, you're just jumping on it. I just want to teach the audience. Did you guys notice also that the scale changed? So his velocity went up and suddenly it's really tiny. Can you point out on your screen if you can with your mouse? So from 24 he went to 34 or 33. Those are the things that I think little tiny nuances. What I would suggest a little bit more also to decrease your color box. Mm-hmm. So I think that way you will help your positive position frequency, and I think that when you want to show this as on a video clip, hopefully later you will see the benefit of that. Yeah, definitely. I mean, the obvious thing you could probably do is also decrease your depth so you can get more of a focus more of your attention to the artery. Mm-hmm. Maybe I got a little bit too excited, but well, definitely, yes. So to kind of also talk about scale and why it's so important, actually filling the vessel, you have a much easier time if you properly adjust your scale. So if you have a lot of movement, typically that movement will get picked up with a more sensitive scale, right? But if you keep pumping it up, it starts to eliminate those smaller signals. So you end up with a very beautiful lining
And you really want to always take your color and or freeze your color over the peak systole, right?
Yeah. And also I just want to point out on the waveform that we had the past medical history of the AFib, and after the successful ablation you can see that this is a beautiful sinus heart rate. Yeah.
All right, moving to the proximal radial artery, following the bifurcation, of course. Nice smooth orangey, but as you can see, the waveform is continuing to increase with the end diastolic velocity.
Are you sure you're on the arm, you're not on the neck? This is look to me like an IC waveform. So I think those are really, if you don't label it properly and you say, those are the things I think very important, that underneath the waveform you see the right radial artery prox label. So I think this labeling helps me to, on the interpretation side, to tell me exactly where you are. So I think that's another point I want to point out, that that label on the, underneath the waveform is really important for our interpretation. Thank you.
I think also a really neat thing is for a lot of exams is using the resistive index. So it's quite an underrated statistic, but you can actually find out a lot of cool, neat things where changes in resistive index can lead to finding out more clues about something like a pathology that's coming in. Okay. Moving to the mid, still nice and clear, right? We don't really see too much calcium. I don't expect to see any stenosis leading up to the point of interest. Velocities are still remain the same. Resistive index is barely just kind of increasing or decreasing.
Can you go back? What
Sure.
is that red balloon on the top of your radial? See, that's the red balloon. I just noticed it. Previously, I haven't noticed it.
Yeah. Is it something that we should worry about? Maybe. I mean, we could probably figure that out soon enough. So distal, I'm starting to take transverse images. Here I'm interested in seeing if there's any increased venous pressure from a possible, a fistula, right?
Mm-hmm.
So also just showing that the veins are clear as well, free of thrombus. And I'm trying to see if there's any pulsatility, right? Any low resistance pulsatility in the veins, which from color flow at least, it seems like you could have a continuous end diastolic flow, but there doesn't seem to be too much pulsatility going on.
No, go back.
Sure.
I think we need to chew on this picture a little bit more.
Yeah.
So you noticed you changed the depth.
Mm-hmm.
You changed your scale again.
I did,
because
yeah.
right now you're going after the venous side. So I think those are the really interesting finding. And not even that, you look at the left upper corner when it says which protocol you're applying. So now you switched from the vascular arterial protocol to the vascular venous protocol.
Right.
And your scale was down to 10 because now you want to study the venous side.
Right. You know me better than I know myself.
No,
sometimes.
come on. I'm just reading the screen.
Yeah. So yeah, just focusing straight over the radial vein just to see if that connection is there, right?
Mm-hmm.
Now, looking at this waveform, would you say you have a suspicion that there's maybe a fistula occurring here?
Well, definitely we are far away from the heart. If I see that pulsatility a little bit closer to the heart, I would just blame it on the heart. But we are quite down on the arm, so this is why this pulsatility is a little bit surprising me.
Right. It should be stronger, right? You would think. Yeah. So moving and just slightly augmenting, right? Just to see if it has a great effect on it, which it does. It seems to have a good chunk, it augments very easily. So again, more clues showing me that that might not be a fistula in the radial vein at least.
Mm-hmm.
Resistive index is reducing just by 0.01. Velocities are continuing to, I think, climb from 108 to 128 maybe. And diastole is increasing. And
do you see that path above your above the radial artery, almost like the same path what we saw on the X-ray, almost like you see the needle mark coming through the tissue just above the artery?
Maybe probably right here.
Yeah.
Yeah, maybe the shadowing right here, maybe? I'm not sure. Right there.
Yeah.
At that frame.
Yep, yep.
Yeah. So here, yeah, we're definitely looking at that pseudoaneurysm that was reported. Here I'm using a power angio, and on the Philips machine, or it's the Affinity, you actually have direction too. So you can still kind of play with the gains a little bit here and there, but there really is no scale. It tries to eliminate that I think like that variable, so you don't really create too much artifact, right? But definitely you can see the turbulence there. So not only are we just seeing this hematoma, but there's an active portion inside of it as well. And you can, it's also represented by the anechoic spaces there as well. Here's I believe a transverse, transverse image or sweep of it, moving downward. And here I'm just kind of hitting it obliquely just to appreciate the space, the residual space. Here I didn't want to squeeze it, so I actually added a bunch of gel, and you can actually see that pocket of gel up here. Yeah. So I think what I'm trying to do here is I'm trying to line up the pseudoaneurysm with the artery so that I can kind of appreciate both the artery and the pseudoaneurysm in the same plane. So here I'm just kind of playing around. And I can see that I'm kind of getting further away from it. I just keep working at it, you know. And you can see on the side right here, there's a bruit as well. Yeah, so that's one. Yeah. So I figured I'd of course just prove that there's patency inside that pseudoaneurysm or partially thrombosed pseudoaneurysm. Here we are. So a much more better profile to get everything all together. Here I'm just looking strictly at the distal segment past the pseudoaneurysm. And Dopplering, I immediately see like this bruit. So transverse, just distal to that pseudoaneurysm, and kind of see that line or pathway right here. I'm like, what is that? And you can see my scale is really high. So something's definitely going on. It's low resistant and high in velocity. And sure enough, even lower resistance, 0.45, 0.27. Look at that end diastole. It's almost matching the peak.
Wow.
Yeah, a bruit, of course. And as I kind of move distally, the velocities tend to taper down as well. Okay, just looking at the radial artery distal to everything, right, including that high velocity with low resistance. So we're back to a multiphasic waveform, very beautiful. Again, I'm just eyeballing this potential fistula, right?
Did you see that blue? Maybe it's tapering. Yeah, this is where it's draining to the left. Yeah.
Let's go back real quick.
Yeah,
see if there was
right
anything left here. It's just a high bruit, or a really intense bruit. So, I mean, my scale's at 19 at this point. So, I'm tracking this right here. I'm curious about this because it's definitely moving, you know, as a low resistance vessel here, right? And as I kind of start intonating this worm or yeah, like color flow here, yeah. And it's showing the same waveform. Yes, it's on different sides of the baseline, but that's simply because it might have turned around, right? We have to assume that it might have turned. And we can see that this is definitely a positive shift, right? It's moving up the arm in this case. So the beams are heading down this way. Flow is moving up towards the beam, so it should be moving proximally.
And look at the scale. I gotta
Yeah.
go back.
Sorry. Oh, here we go.
I think these are the real simple
Sorry.
things that what you did on this images, that suddenly your scale is 48. So you had the venous before you picked up the buoy on 9.
Mhm.
So this is where you're tracking back this venous flow on the scale of 48.
Yeah.
Cool. Thank you.
Back to power angio, and you can see that how susceptible it is, and there's so much artifact created by that buoy. You know, so sometimes not all settings on the machine work well. So that's why you have to constantly kind of change what kind of settings you use or what kind of tools in your toolbox, right?
Mm-hmm.
Okay, just going back to the ulnar artery, just to appreciate the Doppler waveform signals. Everything kind of mimics that distal radial artery past the pseudoaneurysm and that fistula. Okay. Here I'm starting to take measurements of the residual space, and of course with color. But you pretty much don't need that, right, to tell you how much flow, or I mean the borders are pretty clear. Here I'm doing a sagittal view, and here I'm really trying to appreciate how big this neck is, how wide it is. I mean, can you really call it a neck? It's right off the artery, right?
And this is why I wouldn't call it a neck, because you did not really see your special PSA waveform, what we usually see in a pseudoaneurysm neck, because that alternating waveform I did not appreciate. So I think that's where hard to call it as a neck, but definitely that's your connection to the radial artery.
Right. So in a traditional pseudoaneurysm, right, the spacing in the neck is so thin that it has to share that space with the forward motion and the back motion, right? So in this case, because it's so wide, and you can appreciate it in color as well. Maybe I can get another one here.
But I think the Pepsi Cola was there.
Yeah, the
for sure.
Pepsi Cola. You'll have a Pepsi Cola sign just because there's so much space. Yeah. And yeah, that's pretty much it. Sorry, let me get back to
I
there.
would like to show you guys what happened in the operating room. Can we switch to my computer, please?
That's pretty wide.
And
That's 0.7 centimeters, 70 millimeters, or 7 millimeters.
okay. So I would like to show you, and again, this is Travis' finger, and if you just for a moment, I want to go back and watch the beginning of the video. Here he is where the string just came in, and the incision is made underneath. And what you see here is, I would say the body position is listed in the left upper corner, is exactly what we saw on the ultrasound. And just immediately after you have your skin incision, you can see the pseudoaneurysm and a little bit of more. Surprisingly, my surgeon colleagues reported that the pseudoaneurysm was almost occluded the time they opened the skin. And this was again just the next day of the operation, but you can see now the hole. I would say this string gray was so much better than any of my anesthesiology colleagues without any ultrasound guidance, stuck in the middle of that radial artery. This is how accurately, just by accident occurs, but I think this is stunning that how accurately you got the radial axis. And you see the radial artery, you see a little bit of the residual. I think this is the pseudo up there, and again the washout and clearing, and you see the two ties now on each side of the hole on the radial artery, and now you see the hole right there. And what we did is, again, just ligated the radial artery after these positive allentins. And what you see, the patient, again, went home 2 days after the surgery on antibiotics. And these are just few pictures just to understand even from a really tiny stingray, this is what made the injury. And on the top of these really fancy marks on the side, there's a neurotoxin, which is neurotoxin why we have to wash out and need to be careful how you do the fishing. Usually I would do fishing with my boss because I'm afraid to touch the fish. So I will let him handle even a stingray or the regular tiny fish. But it's very important, I think, our first aid is that you just lots of washout, and again a little bit of heat is a kind of destabilizing the toxin, but it's really the painful part why I think this patient really came back again even 2 days after it's happened. Next, I would like to look at if you guys have any questions for us. I do not see any questions. Do you guys see any questions? Next, I would like to review a case of the 62-year-old gentleman with a high-grade carotid stenosis. Please get ready with your carotid. And in the past medical history with peripheral artery disease and 3 previous stroke, the past medical history is still significant for hypertension, and the patient has a wound on his right arm. And this is again another scan done by you, Stephen. Please show us the pictures, and after that I will show you the operative pictures again.
All right. So, starting off with the first image, we're doing a transverse scan of the carotid artery to the bifurcation. Here I'm moving downward with the color flow. Immediately we can see that there's color aliasing occurring there. So that should kind of signal us that there might be some stenosis occurring. We're moving up from the proximal segment of the carotid artery, and immediately we're seeing some high resistance, right? Would you say that's an increased resistance?
Yeah, but I think
typical, right?
Because of the CCA is always a mixture of the EC and IC resistance, but definitely with that high resistance, I'm fishing something that distal, you may have obstruction. But I also, can you go back?
Yeah.
I just want to point out your beautiful setup for the color box. So your color box, and again, definitely just smaller than previously done.
Yeah, smaller and also pointing in the correct direction, I might add, right?
Yeah,
the rhomboid looks good.
Yeah,
right?
yeah. Looks like you definitely don't have Parkinson. So that's always comes handy. That your hand is quite stable.
It's pretty stable, yeah.
For these pre-pictures.
Thank you, sir.
Yes.
Thank you.
I would probably increase the scale just a touch a bit because I still see the aliasing. Do you see the aliasing a little bit?
Yeah, you mean?
I see.
No, I don't see it. Not this
yellow,
one. Maybe
blue.
later.
You see that blue?
Yes, the color scale. Yes.
Yeah,
maybe.
yeah. So this is what I meant. On the color scale, I would just maybe do 50 just to make me happy, because you're teaching that in your school that, look at your scale 100, then maybe do the 50. I learned that from you, man. So thank you for teaching that.
That's true. I can't deny that. All right, so here I'm actually backing down on the scale, right? Like, you see this?
Great teaching. Thank you.
Yeah. So, but like by this time, because typically from the proximal segment, because it comes right off the subclavian, if you're really proximal, a lot of times your velocities are increased, your resistance is increased, because you're kind of sharing this hemodynamic thing with the subclavian artery, right? Yep. So by now in the mid segment, you should see more low resistance, right?
Yep.
But that's kind of not what we're seeing yet. We're still seeing some increased resistance here. So better, right? Slightly better waveform. Now we're kind of zooming in and zeroing in on the ECA. We can see a focal plaque formation with some shadowing. And I love this. I love B-flow. I can't get enough of using this off the GE. Man. Yeah. With some color flow adjustment, scale adjustment, I'm looking at that segment, and because this segment here kind of slants upward, I want to change my box to kind of match the angle of the vessel. And sure enough, with the proper scaling, we can see the increased velocities are focal, right, at that specific point. And this really helps helps you in determining where the highest velocities are. That way you don't have to walk the Doppler, right? You can immediately find where you should be sticking your sample. And as you can see, consistently back to back, we're hitting peak systolic velocities greater than 150, which on our criteria is greater than 50% stenosis. Looking at the back end or the distal segment, we don't really see turbulence, but we still have increased velocities. And the waveform looks quite nice. There's got a lot of characteristics in there. Kind of sweeping back and forth, we can see that there's scattered hard plaques in the mid segment. But okay, and I'm just trying to see if there's any focal aliasing. So I probably could have increased my scale there to kind of look.
Yeah, I love the B-flow though.
Not really seeing any narrowing, right, throughout that segment. But I still kind of chase and look around. The velocities are still maintaining a similar peak systole. Now we're looking at the ICA.
So before you look at the ICA, what else would you look on the ECA in this setting that, let's say that we know that there's maybe a high-grade stenosis? So I was surprised to see that I did not see enough end-diastolic flow. So is this ECs internalized or not?
Yeah, so based on those waveforms, I would say it's not internalized. Internalization, you would look for maybe a resistive index that is closer to like what, 0.7, right?
Okay.
0.8, maybe 0.8 at the very highest. But
and just for teaching point, please tell us, the audience, why the internalization would make sense on a TCD. So what would you look at the ophthalmic and how would you map the collateralization? So again, if this disease is proximal enough, you have collateralization pathway from the ECA through the eye, through the thyroid superior. So this is where you are looking for any collateralization, not just to see, I have a 50% ECA stenosis, but what else you look for? Right.
So I always like to do carotids first when we have these TCD and carotid combos, just because I feel like I can get more information from the carotid first, and I'm not surprised by the TCD. So based on this waveform so far, or knowing that the ECA is high resistance, right? Internalization refers to the collateralization moving, or a flow moving into the ECA, where in this case, we're looking to see retrograde flow in the ophthalmic if there was internalization occurring, right? So because we're still seeing that most flow, or the MCA is probably still supplied mostly by the ICA, right? Because then we would probably still expect to see an antegrade ophthalmic artery. Right? Yeah.
Very good. Thank you.
So just kind of skipping around, but looking at this sweep here, I always like to do sweeps. It you know, they say a picture, you know, says 1,000 words. I mean, a sweep is 1,000 pictures, so you know, why not make it 100,000 words, right?
What's your frame? It's only 140, so it's not 1,000 frame. Sorry.
So also another note that I like to kind of point out is how we utilize gain in these kind of settings. You don't want to get too high to the point where you don't really see anechoic spots, but at the same time you also don't want to be too low, because then you'll start missing soft plaques especially. So also I would say our system DigiView tends to be a little bit more on the dark side, right? So if we bring up the gain in the exam or on the machine, the post-processing and features actually help out a lot more, especially increasing the brightness, right? Or decreasing, really. Decreasing is a lot, you can appreciate things a lot better than increasing, and here's kind of like a, show
the same on the B-flow, because I think on the
B-flow,
so darken the B-flow a little bit.
Yeah, you can definitely appreciate that more, huh? Yeah. It's tight. Yeah. And here's a couple color flow settings. So if we kind of just move this out of the way, you see that here I'm choosing to use a scale of 40. Whereas if we move along, we can kind of see pinpoint where exactly is the highest velocity. It's not here, it's not here, it's right there, right? So increasing that scale, really important. So I'm just attacking it right at that point, and we can already see like really high velocities. I'm just going to kind of move around. Here I'm using the box and pointing it away from the CCA.
Mm-hmm.
And here I'm just kind of heel and toeing and choosing to change that slant, because I'm seeing that this color here, it's kind of pointing slightly upward, right?
Yeah.
And slanting out downward this way. So.
But it also show us compared to the previous image how
Sure.
your numbers got better though.
Yeah.
So I think here you see on the bottom the velocity is 454 over 176.
Mm-hmm.
Next, you see 578.
Yeah, that's a huge increase. We're looking
Yeah,
at like 120
126.
20-something% increase.
So based, if you just show me this one image,
Mhm.
what would be, based on our criteria, the grading of the stenosis?
Well, for stenosis, 50 to 69%, we're looking at 125 peak systole, 40 end diastole, and we're expecting to have a IC-CCI ratio between 2 to 4, right? In cases where it's higher than that, so we're looking at 70 plus, 70-99%, we're looking at is it 225 or 275?
Or 230?
230. Okay, yeah. 230. You're right. It is. Yeah. It is. It is 230.
I hope we are not recording
Man,
this
you know, sometimes it's like, you see a picture.
You failed on the interview.
I
right
know.
now. These are one of our interview questions for our
Yeah,
new
we do. We're
sonographer.
hard on our interviews. We are. We want the very best.
Yes, sir.
So if you're out there and you wanna join us,
Learn
yeah,
how to
230. 230. Learn your criteria.
Very good.
Okay,
And
yeah.
diastole?
And diastole, we're looking at 100.
Very good.
Yeah, 100.
But just
Ooh.
looking at the diastolic flow of 260, we modify the consensus criteria for an 80 to 99%. Because
Yes.
we believe if your end diastole is over 140, this has to be tight. So I think it's helping, instead of calling something, oh, this is barely 70%, you're helping with narrowing down that 70 to 99% to 80 to 99
Yeah.
to take it seriously. I think previously was for the asymptomatic carotids to really pick those really high grade stenosis, but here there's really simple, and I think on the waveform I see the bruit also, so the snowball sitting on the zero line, that is a snowball, so we don't have too much snowballing in winter time, but I think this is what I see, a snowball on my zero line.
So between 70% and 80 to 99%, is there a difference in care here?
So I think I think we need to go back to the Spencer-Reid curve. Remember that curve when the velocity started to go up, and the danger here that you may be on the other side of the Spencer curve. When you're measuring a really hemodynamically significant stenosis and your velocity is so high that you suddenly, your velocity just can go up high. This is like probably 600 is maybe one of the max scale on one of the machines.
Okay.
And you may be on the other side of the Spencer curve and it's dropping to the near occlusion or to occlusion. So I think that would be the significance, and hopefully you will show us that after the stenosis how much velocity drop you see. If your velocity drop is significant and drops to less than 100, then you know that you're on the other side of the Spencer curve. If this velocity is only dropped to, let's say, 150, then you may be still on the upper on the right side of the curve. So let's see what you show after the stenosis.
So I'm just taking multiples because you can't prove anything without you have to replicate the findings, right?
Yeah.
Definitely more of a bruit as we move into the turbulence. And wow, look at that waveform, right? Complete obliteration of the arterial signal.
This is I don't know, I haven't said as a term, but maybe I call this as an unorganized waveform. So suddenly, like, you really don't see that arterial waveform, but all these spiky waves are really representing all these variable velocities throughout that flow pattern. But even it's interesting that you see maybe a respiratory variation there.
Or my hand could be moving, but look at that. Yeah.
Can you go back?
Sure.
I just want to see your systole peak and your diastole. So, where do you put your cursor on that systole peak? One more time.
Oh yeah, like my thought process on this. You know, I thought that was it looked decent, I guess. I couldn't tell you. You know,
this is when you need to use digi and you make it darker so your peaks are disappearing above your star.
Yeah, you're talking about this guy here. I mean,
yeah. Well, it's close enough.
You know,
but I think see the velocity is under 100.
Uh-huh.
So you had a 600 over 20. 600 over 200 drop to 95 to 35. So that drop is what's telling me that you may be on the other side of the Spencer curve.
I see. Yeah.
Cool.
Definitely not 150. You know.
Yep.
Oh, hang on. Did I freeze? Oh no, I'm good. So you can start seeing it's coming back here. Mm-hmm. Yeah. And then the distal segment that I can get. Mm-hmm. I mean, you got some delay and upstroke, but for the most part, I mean, if you saw this waveform, would you have thought that it was, you know, 80 to 99% stenosis?
No.
I would expect more of a
way
TP,
much
right?
More blunting,
yeah, more blunting.
Mm-hmm.
So, vertebral artery, I always like to get B mode before I get color. I don't know what, you know, doing the color flow first, it kind of it gets in your way. You know, when you move the probe like this, you're gonna run into a lot of artifact created by, you know, the movements and Doppler shift,
and also the anatomic size. So I think you see on the beam mode clearly how big is your vertebral artery, and I think it's really without the color. Oh, tell us about this clip, because I think it's really interesting clip when you want to.
Yeah, we always like to add this to our protocol, but this is the sweep, the vertebral to carotid artery sweep. We're interested in seeing if the vertebral artery is antegrade in this case. So a couple pointers: if you move more posterolateral, you can bring the vertebral arteries a little bit more superficial and you can appreciate them better. But in turn, the plane of your carotid artery and your vertebral artery are going to be different. If you want to stack them on top of each other to get both inside, to not have to do the sweeping maneuver, you really have to move more anterior on the neck. Yeah, in order to get that image.
So also the direction, I think very important point. Also the vein on the top of the artery helps you that they are going to different directions.
Yep.
So you have the excuse from comparing to the carotid. Second is you're looking at, again, the direction of the vein and the artery, and the last one is the waveform. So I think we want to see also the waveform being low resistance, not high resistance. Show us.
I will.
Good. So it's an antegrade vertebral.
Antegrade for sure.
Surprisingly, not too much increased velocity. So those are the things that I'm looking at. If you have that significant right AC stenosis, think about collaterals at the same time. Do you have increased velocity in the vertebrals? Does it provide the posterior PCOM collaterals or not? So this was a nice sizable vertebral, and if you take out that carotid, you want to redistribute that flow through the vertebral and the other carotid system. Okay.
I think another note, leading back to the point about looking at the vertebral in B mode, a lot of times when you see that the vertebral artery is actually quite small, right, in diameter, and then you follow it up with a Doppler signal and you see that there's high resistance in it, then you start thinking, oh, what am I looking at? Is it hypoplasia, right? Hypoplastic vertebral artery? So that's one thing. Moving on to the subclavian, that pretty much ends our protocol here. We're looking at triphasic waveforms, but then as we move distally, because you know this isn't your typical triphasic waveform, right? There's something odd about it. You can see like there's this huge, it's so like it's moving below the baseline so far that it's aliasing. You know, you see this? Yeah, so it's like, okay, something's up. You got to move distally, and sure enough, as we kind of move distally, this thing's almost off the graph on a max scale. You know, that's high velocities. Of course, gotta follow up with B mode because I love that stuff. Distal turbulence right here, guys. Right. So here I'm just trying to find that point, and yeah, just bending the box.
Can you go back to the previous one?
Sure.
Because you see some struts there. Are those struts on the, see that on the right hand side in the corner?
Right here?
Huh?
Yeah.
So I think that also give you a clue that this is a disease subclavian and maybe some hardware already put in there.
Mm-hmm. Talking about physics too. I mean, this is a straight box at this point. That means, you know, your amplitudes and how you say it, Doppler shift is supposed to be at its lowest point, right?
Mm.
Yeah, but it's also aliasing with the 60 scale. I mean, even if I were to push it up, like even to 100, I'm pretty sure it'll still be aliasing. Looking distally, yeah, definitely seeing that turbulence here with the jagged peaks. And of course, always want to add in volume flow for, you know, that extra oomph.
So tell us why you're using volume flow.
Okay, so
Is this an AVF study for some reason?
No. So volume flow, right? We actually ran into a situation where we had a patient that had bilateral 70 to 99% stenosis. Was it higher than 80?
Yeah.
It was 80, bilateral 80. Whoa, yeah. So now we come to the decision. You know, which one do we tackle first? Which one do we do surgery on? So if you pick the side that provides more flow, then, or if you determine which side has less flow, then if you repair that, or I'm sorry, so the side that has more volume flow is the side that can provide the compensatory flow to the other side.
Yes.
So then you would fix the
Other
other
one.
side. Yeah. Sorry, guys.
Very good.
Yeah.
It's so confusing. Then suddenly it's like
I do better with diagrams.
Okay,
Yeah.
very good. So when your volume flow basically is higher with the bilateral 80%, then may provide collateral to the other side, and you're risking bilateral ischemia when you're clamping that. So
Right.
the rationale behind it that you want to fix the side has less volume flow that you're not risking bilateral embolization, and then you can fix the other side as well.
Yeah. So main point, you want flow up there. So
Yeah. So
pick
can you go back and
sure.
remind me what was the
so
low volume flow is
260-ish.
260.
Yeah.
Just remember 260.
260.
So
All right.
what will be on the healthy side? And scroll through this really
Yeah, let's
faster
go.
because we only have 10 minutes left.
So just looking at that, you're gonna see some aliasing. Sorry guys. Some plaque, but not significant enough to cause stenosis. It looks like. But there is some turbulence and increased velocities in the proximal segment, more than normal. That's 255. That's a little high, and you're seeing distal turbulence as well. So at that point, you would maybe assume that there might be some kind of proximal stenosis going on, but it's all suggestive. Some soft laminated plaque here. Not seeing that pinpoint aliasing though. Turbulence still, but no increased velocities. So at this point, we're seeing velocities kind of taper down from a tighter spot. If you were to use a segment to do the IC-CCA ratio, of course the other two aren't going to be viable because one, you have super increased velocities that might be due to stenosis. There's definitely stenosis here, and you would probably want to use the distal segment to do your calculations off of. B-flow in the ECA, you're seeing some aliasing, so yeah, but not over 150. Kind of trying to creep closer to the plaque, and I'm not seeing any increase in velocities there. So looking at this B-flow with the ICA, we're seeing that the residual diameter is not too bad. We do definitely see a narrowing here, and we can't really see this portion here due to the posterior calcification. A couple ways you can tackle that is to kind of move around the neck, change your planes, and see if there's a chink, chink in the armor, so to say. Definitely getting 150, 169. So as we last covered, anything over 125 peak systole should be concerned for greater than 50% stenosis. Here we're actually kind of seeing some hits, right? Would you say? Maybe
hard to tell.
Right?
I think this is the same thing as maybe in a little bit unorganized waveforms, and sometimes you see those, or maybe can you decrease the color again on the spectrum with
this here, Maybe, right? But
Maybe,
still,
yeah.
You're kind of seeing some of these
something.
here.
Yeah, but see, the point is that it appears in each cardiac cycle, so it's not randomly appearing.
Right, yeah, that's true.
So that's why I'm not buying this as an embolus, because you look at the last waveform, you see the same spot.
Yeah.
The third one, you see the same spot.
Right here,
Those are
right
maybe
here.
just clicking sound, the fact that you represented in a waveform, but because it's needs to be randomly appearing if you want to blame something on an embolus.
And I think, and just to note, I think we also did a embolic monitoring.
Yeah.
Yeah, on the TCD, and we didn't see.
I think it
hits.
was negative. Yeah.
So changing my rhombus here,
Mm-hmm.
I'm reaching further into the plaque. It allows me to kind of point my Doppler signal so that I'm hitting a little closer to the center,
Mhm.
and that allows me to get a better velocity here
Yeah,
too.
yeah.
So 160. All right, kind of trying to move around.
I wish you did the same angle with your B-flow, because I think on the B-flow node we'd almost connect with that one.
B-flow is like a straight. It moves with the 2D, so it's still gonna move downward. You could actually
what I
aim
mean
it though.
is separate to come around your calcified plaque instead of more anterior, use more posterior approach or something to go around the
Right.
calcified plaque.
Okay, looking at ECA, not greater than 150. I'm still kind of trying to convince myself that there might be stenosis. I'm trying to fight for it, but you know,
Yeah.
it's close but no cigar, right?
Mm-hmm.
Looking at mid, we're seeing some blunting, and distal, same thing. You have a delay in upstroke, so definitely you should be concerned that there might be stenosis.
Just show me the
proximally.
volume flow,
sure.
man. I want to see the
Sorry.
volume flow.
Similar vertebral, by the way.
Yeah.
Yeah.
More-
And a carotid subclavian bypass graft.
Yeah.
Patent.
Oh, wow. Okay.
All right, just moving.
That's a
moving.
good surprise for the other side. And the volume flow is yes. So
408, yeah.
So definitely volume flow is
418.
kind of helps you to really, again, what we just stole from our AVF protocol to confirm that that right side was definitely significant, not just the velocities, but here's a volume flow showing. So volume flow range, what we learned from the literature is about 350 for sure, and can go up to as high as 700. Can you switch back to my computer? And for closing, we're almost out of our hour. I would like to take you back to the operating room. I would like to show you what we saw. So again, Stephen did the carotid and also preoperative TCD study, including a negative emboli detection on this patient. And this is my view in the operating room. So surprisingly, before we even started the case, I want you to hear the sound of this baby. And I hope you can hear enough from my microphone. Now I'm going to decrease the gain. So with the decreased gain, you need to keep your eye on this. Boop. Did you guys hear that popping sound? So I'm not making it up. This is now real spontaneous embolus. It's appeared in diastole. I hope you guys could hear that one. But the view, I think, is really stunning when you see that now we are putting a clamp on, and watch your TCD monitoring for the MC on the right side. So here comes a clamp in the hand of the surgeon, and watch the percentage, which is 91%. And from the 91%, it's dropped only to 65 or 70%. Our protocol is by increasing the mean arterial pressure, and we're able to keep up the delta percentage about 50%. We're not going to shunt the patient, and we're able to just proceed with endotherectomy. And you see it here that, again, here comes and I just want to scroll a little bit faster. I want to show you how the plaque looks like, and I will have a picture. Because surprisingly, there was like a clot sitting on the top of this plaque, and this is why it was embryogenic. And again, here comes the shunt, and after the shunt placement, we will have some plaque coming out. This was again the surgeon's choice to able to see, and when you see the shunt is in, see the embolization. So this is what you can prevent if you don't put a shunt in. When you see this embolization, the second important information that you see, you restore the blood flow to the middle cerebral artery. So you provided 100% flow. And after we finish the surgery, I would like to show you when you release the clamp. Again, you're restoring the blood flow in the middle cerebral artery with 1 or 2 hits representing just a few emboli, and you see the suture line, and now you see no hyperemia. Your waveform doesn't really follow here, but again you can see there's no flow pattern. And this is what I want to show you. I took a picture of this. Is where you see this is the hemorrhage, and this is right now is an open. This is why you're really not appreciating truly the high grade stenosis, but this is how ugly this plaque was after we took it out. Well, we did not receive any questions, and just closing the hour, I would like to thank you for staying with us today. Stephen, thank you so much for your beautiful pictures and for your hard work. Yeah. We would like to remind you one more time that please join us on October 24th on a virtual conference, the Vascular Ultrasound Master Class. And also before you, October 24, if you have a little bit of free time and after a hard day's night, please look at the Vascular Ultrasound Masterclass on demand, and just stay tuned and look for more cases coming out monthly in our Vascular Ultrasound Masterclass. And again, thank you so much for staying with us today.